Yeah. सही है तो ऑडियो सही नहीं आ रहा ऑडियो सही नहीं आ रहा
तुम क्या क्या ऑन किया यहाँ से तुम उस पर जूम भी ऑन किया यहाँ पे खोल कर रखा है क्या तुमने यूट्यूब पहले उसको म्यूट कर यहाँ पे भी यूट्यूब खोल कर रखा है अरे इसमें भी यूट्यूब खोल कर रखा है
यूट्यूब तो भी वाला है
कौन सा वाला
जो लाइव है वो हाँ
ठीक है वहाँ पे देख के आ रहा है अरे डेस्कटॉप कैप्चर तो लेना था क्या लेके
स्टडी जो था कहाँ है
कहाँ है ये
डिजिटल कैप्चर ही
hernias, the scope, the breadth, and what are the options for the surgeon? What kind of cases would you be safe doing? What kind of cases would you be better off referring? So let's kind of get a more in-depth perspective from people who have dealt with it in real life. So we will start off with Charlotte Horn. Many of you are familiar with Charlotte. She is becoming one of the star speakers in the Asian circuit. And she has given several talks to our audiences. And today she's going to give us her perspective. Charlotte, please take over.
Awesome. All right. Well, I will start by first off sharing my screen. And then, as everyone always asks, whenever you do this, can you guys see my slides?
Yeah.
Awesome. So finished my fellowship with Rosen at the Cleveland Clinic, and now am Paul Ide's junior partner here at Hershey. While I was doing my fellowship, we were working on a trial where we were trying to figure out whether or not a TAR with a keyhole or sugar baker repair was better in terms of long-term recurrence, wound infection, all of that stuff. So that data should come out in a couple of years, but it did mean I had a wonderful opportunity to do a ton of peristomal hernia repairs. And I have to echo what Ramana said, is the only thing that I remember, or the thing that was most noticeable about my fellowship, was that every single week I seemed to be presenting some sort of morbidity because of a peristomal hernia. And it got to the point at the end where I would take a picture of the stoma when I left the OR just so I could prove that it actually looked okay. My disclosures are just that I'm a lecturer for Medtronic. So I wanted to kind of talk about what are the repair options, as well as some of the pitfalls and things we've kind of learned as we've kind of progressed from just, doing initially sugar bakers and then the keyholes and some of the ways we've been able to analyze our complications, and then kind of discuss an algorithm for repair. And then, I think as Ramana had mentioned, because these are so complex, you kind of have to just expect that it'll recur and kind of come up with a plan for how you're going to manage your recurrence if and when it happens. So I like to say that peristomal hernias are the gift that keeps on giving. 50% of stomas will go on to develop a peristomal hernia, and I think the only way to prevent that is to try and take the stoma down. And then on top of that, not all stomas are created equal. There's a significantly higher rate of peristomal hernia formation with colostomies compared to ileostomies and ileal conduits. Loop ileostomies are lower, but then I think that's simply because those get taken down. So we really don't follow these out as long as the end colostomies and end ileostomies. And so why exactly is this problem so complex? First off, you have to make a hole. So you're making a hernia to make these happen and trying to find the right size of the hole that will only allow the bowel to get through. It's not too tight. Like, things have to be perfect. On top of that, sometimes when you're redoing these or fixing them, you have to take a stoma down. And so you're putting mesh in a contaminated field, as well as you're having mesh that has to interact with the bowel that can cause a big wound problem. And then on top of that, if the patient has other hernias, if they've had previous stoma sites, there can be previous incisions that you have to work around. So in general, kind of approaching these patients requires a very, very thoughtful, and they can be complex. So you kind of really have to address a lot of things when you're trying to fix these. And on top of that, I think, some of the early data that we looked at when we did these peristomal hernia repairs, the recurrence rate is still not great, around 20 to 25% with the TAR. So that is still not wonderful. And so I think on top of that, you kind of have to decide, is it worth to do something very, very large, knowing that, they do have a significant risk of recurrence. So, if these are so hard to fix, I guess the question is should we even be fixing these, or is there other things that we can do? Or is this kind of well, this is just kind of what you get? I think, there's obvious reasons to fix them. Obviously, if they're having obstructive symptoms, they do need an operative repair. And I think the morbidity of either a poor stoma or a loosing fitting appliance, I think, is something that is really underappreciated by people that don't have these problems. The skin excoriation and difficulty with appliances, as well as the significant lifestyle limitations if you have a constantly leaking appliance just because of the stoma, I think really necessitates a repair in these patients. And so I think, while these hernia repairs are complex, there's certainly a lot of indications to fix them. So what are your options for repairs? I think you can kind of break them down into sort of local repairs, which would be the primary suture or an onlay, or you can relocate the stoma. You have options for minimally invasive repairs, as well as some of the larger complex open repairs. And I think when you're kind of trying to decide what repair is most appropriate for the patient, you really have to look at a lot of patient factors, as well as, things that you may have not considered, like what is the patient's disease, age of the patient, how big is the hernia defect, and we'll talk a little bit about that later. So I also say it's kind of like a game of chess. You have to stay one move ahead because, while it might seem like, hey, in my practice, we did a ton of open complex peristomal hernia repairs with TARs, the PPHRs, but if it's an 85-year-old patient and, it's an ileal conduit and their hernia that is that big, if they recur and become symptomatic, do you really want to be doing a redo peristomal hernia repair in that situation? So I think that, this might be one of the few cases where it makes sense to do something that may have a higher rate of recurrence up front, just knowing that they're probably going to recur, and kind of saving some of those planes to do a more complex repair down the road is something that might be worthwhile. And I think, we really changed the way we interact with patients when we see young patients with stomas. It's kind of I'm going to be your surgeon for the rest of your life. We're going to really get to know each other, and we're going to work together, because it's certainly something that necessitates a long-term relationship with the patient, because we do know that the recurrence rate is so high. So I think when you're first evaluating a patient, I think you need to say, do I really need this stoma? This person had a complex hernia. Obviously, they actually had neck fascia of their abdominal wall, and they had a end colostomy. And, that was done because of perforated sigmoid diverticulitis. And in any situation we can, we try and take the stoma down so they're done with the stoma in entirety, because that certainly makes fixing the problem a lot better, because you're just fixing an incisional hernia at this point. And so I think, a lot of times we are referred patients and they said, well, I had this, I was told it was never reversible. It's definitely worthwhile to investigate that and kind of figure out what can you do? And then the second question, is it worth changing the stoma? So when addressing that is kind of twofold. Number one, if they have like a transverse colostomy, but a really big peristomal or a midline defect, and you know they're kind of stuck with that, you know, is it worthwhile to do a completion colectomy and do an endoileostomy, because you know that there's probably lower likelihood of recurrence at that stoma site versus a colostomy? Or on top of that, it's kind of like, where should I put the stoma on their abdominal wall? Should I relocate it or keep it where it is? So I think both of those situations and questions need to be asked with the patient. And I, wouldn't routinely advocate for it, but it's something that makes sense if you have kind of a younger patient and a colostomy and there's no real indication for them to have the rest of their colon, or let's say they've had a stage procedure for ulcerative colitis, then, kind of doing something that will allow them to have a lower recurrence rate long-term is worth it. The other thing that you have to consider is how you're going to manage concomitant hernias, whether it's a midline hernia, whether they've not had a hernia at another stoma site. All of those things kind of will guide your decision making. And then on top of that, like the disease process that will necessitate the ostomy. For example, if you have a patient that had Crohn's disease or ulcerative colitis, and for some reason they haven't had the completion colectomy, or they're, need routine surveillance, but that they will need future abdominal wall or abdominal operations, it might make sense in those situations to just do something smaller, knowing that there's a pretty good chance that they will in fact have another abdominal surgery, and coating their abdomen with mesh might not be the wisest thing to do in those situations. So when it comes to local repairs, I think that the biggest con with these is that they have a pretty high recurrence rate. But again, in the right patient, they're completely appropriate. They're simple. You get to work right around the stoma. There's a really low morbidity. And so, if you have an older patient, it's a very small defect, it might be the appropriate operation. That being said, in someone where that they're going to have the stoma for a while, they have a lot of, or they're young, then it might not be the right thing. So I think that a primary suture repair for the right patient is a great repair. But again, it's kind of picking those right patients to do that repair on. The local mesh repair, I will say it is an option. It's not one of my favorites, simply because I think you have to create a large subcutaneous pocket in order to get a nice mesh overlap. It is still got a pretty high recurrence rate of almost 40%. And I don't think it's a great definitive option. That being said, there are some times when you find that you have a recurrence after a large posterior mesh-based repair, and I think that in that situation, if they have a small defect and you want to reinforce it, maybe an onlay might be something that would be beneficial in that patient. The other option is stoma relocation. I think that recurrence rates again are still high. You are now making a defect in a situation, you kind of will have to mitigate the risk of herniation at both defect sites. One of the downsides of this compared to just a local repair is that you have to do a midline laparotomy to move the stoma. And so on top of that, you have a midline incision, you have your old stoma site, and you have your new stoma site. And then you kind of get into this question of like, do you reinforce your new stoma site with mesh? And I think the literature on that is, a little bit uncertain. And then do you put mesh at the old stoma site? Like, how are you managing these incisions that you're making? And so I think that, if you're going to relocate the stoma, you have to have a really good reason as to why. And I think that, peristomal hernia alone probably isn't the best reason to do so. If they have, significant pouching issues just because of where it is on their abdomen, or like really bad skin breakdown from leakage, then it might make sense to relocate it. But I think just as a reason for, or a way to fix a peristomal hernia, I wouldn't recommend a stoma relocation alone. And then some of the minimally invasive options. So you have the keyhole, the sugar baker. I think that as we become more facile with the robot, offering a peristomal hernia, a PPHR, or a keyhole with a TAR will be something that will be more commonly utilized. The nice thing about this is that, you can also combine a minimally invasive approach with some amount of a local approach. So, if they have, you're not able to mobilize things entirely laparoscopically, but want to put a piece of mesh in, I think that that's reasonable. You can go around the stoma, kind of resite things right there, and then do a mesh-based repair from an intraperitoneal position. And so I think these are great options. And I think when you're kind of evaluating patients for this, combining a local repair with a MIS approach and, really trying to optimize the best repair for the patient, you kind of have to think a little bit outside the box as to what you want to do. Again, one of the things with these is they're ideal if they have very small or no midline component. And then in general, it can be really hard to dissect all of the bowel out laparoscopically safely or robotically. And so in general, if you're dealing with a smaller hernia, these are probably a better way to approach them. So I'm going to spend a little bit of time talking about open peristomal hernia repairs. Obviously, this is kind of what I did a lot of my training in. And we're going to talk about whether or not a keyhole or a sugar baker is better, what sort of mesh to use, and then whether or not relocating the stoma is worthwhile. And I think certainly the practice has changed from my years of residency and then fellowship. And so, obviously, there is no data to say which one is better. And so a lot of this is just based on my own bias, as well as my own experience. And hopefully we'll have some good literature out shortly. So, as we progressed through my fellowship, we were a lot more aggressive about operating on patients. The Rosen group kind of said, maybe smoking doesn't matter as much. We certainly were a little bit more aggressive about weight, a little bit more flexible when we're doing TARS of a BMI of 40 was okay, not great. We'd still recommend that patients get weight loss. And then on top of that, if they were diabetic, we did like their HbA1c below 8. But the one group that was truly excluded from all of those things was the peristomal hernias. Like, you're dealing already with a clean contaminated or contaminated case. And you know that their wound morbidity is high, their recurrence rate is higher. So this was the one group that I think it's worthwhile to take a step back and really get the patient optimized for surgery if you have the luxury of time to do so. They will definitely have a better outcome, and I think it's really important to invest in that relationship with the patient. So they know that you're going to fix this, but you know that there is a lot of things that you're kind of trying to mitigate. And so they're more interested in kind of investing in their outcome. And so for these patients, it's certainly a hard stop, making sure that they're ready for an operation. So, the keyhole, we did this a lot when I was probably a chief resident and the beginning of my fellowship. I think this is a great option. You'll see here, we actually had Stranus as our posterior layer. That was simply because we were operating in a trial and not our routine practice. I think a piece of polypropylene mesh is totally safe. With these, in order to do this, we never really cruciated the mesh around it. It was always take down the stoma and recite it through a hole. And I think this is a decent operation. I will say my inherent bias is that I like a polyperistomal, and not because I work with Dr. Pauli, but I think it's a little bit of a better repair. And so this is why I think, there are a lot of things when you think about when you do a keyhole repair. You have to make sure you have a posterior sheath hole that is the perfect size. It's not too tight. It's not too loose. Then on top of that, you have to put the mesh in, and the mesh has to be completely aligned with the posterior sheath hole. Can't be too tight, can't be too loose. Then on top of that, you have your anterior fascia, which again, completely aligned, can't be too tight, can't be too loose. And then you still may have some issues in the subcutaneous tissue. And I think, this is one thing that is a little bit, unfortunately, of just a surgical gestalt, where you can say everything is in a line, it's perfect, but you can imagine it is so easy to, if you don't pull the stoma up entirely straight through all those layers, you kind of scissor everything, and the end result can be, unfortunately, devastating. This stoma actually died because it was an anterior fascial problem. And so we were lucky enough to just kind of resect it and be able to mobilize a little bit more of the stoma and recite it. But There are so many layers that you have to be considerate of when you're doing this. And I think the other thing that can be difficult is it's a little bit hard to predict long-term how that mesh is going to contract. And so if you make it too tight, obviously you're concerned about mesh eroding into the bowel. But if you make it too loose and that mesh contracts, you're going to have a recurrence. And so I think, you know, although there is no data to suggest that this one is worse, I prefer kind of doing a polyperistomal simply because, you know, there are so many layers that you have to line up. And I think, you know, you could be an excellent surgeon and still one time it just causes you a problem. And so for that reason, I do prefer the polyperistomal. Maybe decreases your wound morbidity a little bit. There is a lot of ways to manage the stoma. Some people kind of sew it closed. You get to have the stoma completely out of the field. You're not taking it in and out of the abdominal wall. So I think, you know, from a wound morbidity standpoint, you know, leaving up actually makes the wound, although this is no evidence, a little bit cleaner. The only caveat to this is sometimes it can be difficult to lateralize the stoma. And so ileal conduits can be difficult any single time you have a continent stoma that they have to cannulate in order to empty. You can't do this repair because there's no way for them to kind of snake it around the S. And I think that hopefully I will be proved by saying that there is a decreased recurrence rate. But when you kind of think about it in my mind, if you kind of are offsetting the holes enough, you kind of have a much or a decreased recurrence rate, because even if that mesh shrinks a little bit, you know, your hole is not kind of reinforced entirely by a ring of mesh. And so I think that this is kind of a little bit nicer of a repair. And then on top of that, while, you know, obviously you can still interaction that the mesh has with the stoma. And so hopefully you are dealing with less mesh erosion complications. What is kind of the best way technically to approach this? So, you know, leaving the stoma in situ, first thing that always has to happen is so you can kind of work from both sides. We would always start, you know, from either side of the tar, and then so that you can see almost circumferentially around your stoma, and then you can work behind it and advance it. And then in order to get the enough lateralization, number one, you have to make sure before you're doing your actual abdominal wall component that you have enough reach and length with your bowel or colon. And then we basically make a slit in the posterior sheath almost all the way down to the white line of Tolt to get it to lateralize nice. And I think, you know, sometimes when you're doing this, you kind of don't think it's lateralizing as much as it is, but just remember to pull on the anterior fascia so you can actually see that you get a nice lateralization of your stoma. And then we sew the posterior sheath from where the ostomy is all the way to, so that you can close that defect, as you can see here. But, you know, obviously what we have learned is there is no repair that is great and imperfect. I will say that we have significantly changed how we take care of these patients. We started with putting in so where I trained, we were routine transfascial people. And so there would be a transfascial suture at the xiphoid and the pubis. And then we normally do 3 on each side. So when we started off doing these peristomal hernia repairs, we would do the xiphoid and the pubis, and then maybe 1 or 2 on the side of the stoma, and then 3 on the other side. And that resulted in a lot of mesh erosions, presumably from the fact that you kind of have the mesh taut and your stoma in there, it can kind of guillotine your stoma. So we have gone farther away from fixation to a point where if we're doing a sugar baker, a polyperistomal, we will not fixate the mesh. We make a pocket big enough and just lay it in there. Or some people choose to do a xiphoid and a pubis suture, and that's it, just to kind of make sure things lie flat, and that that the mesh is all flat in that space and it's not folded or anything like that. I will say we have completely got rid of our ERAS in these patients. They're always with us. Like when I tell a patient, like, you're with us for 7 days, and the ileus rate is about 20% from the patients that we looked at. We always do retromuscular drains, and we always put them on the opposite side of the stoma. I think that, we don't have a lot of literature on it, but I think a lot of people, at least in the US, tend to do a antibiotic irrigation, a pulse lavage on the posterior sheath. Sometimes they'll do it on the mesh because you are dealing with a clean contaminated case. The one thing that I will say that I don't really like the Sugar Baker peristomal hernia repair is when you have a very, very large peristomal defect and you're closing it. A lot of times, if you close it and you have the stoma all covered, closing it can really kind of almost crater that stoma and make it very difficult to pouch. And so while it's a wonderful repair option, I think you just need to be very, very careful about how you're closing your peristoma, like the actual defect around the stoma, because that can cause a lot of subcutaneous issues or really kind of pull that stoma down and make it difficult to actually pouch that stoma. And so that might be a reason, unfortunately, that you realize kind of towards the case, you can take the stoma down, try and resite it. But that can be a problem with these as well. And then at the end of the day, I think, we like to say that this is the best thing in the world. My recurrence rate is really low. I mean, I would be cautious if a surgeon told me that, because I don't think any peristomal hernia repair is that great. And so, we are doing what we can and trying to learn as much as we can about these hernias. But I think that just kind of knowing that this is something that you'll be dealing with long-term really kind of changes your perspective about how to approach these. So when it comes to an algorithm for repair, what are your repair options? And I think, I'll lay this out here, but I certainly think, we'll go into it a little bit of detail about, kind of the biases that I have now assumed after doing a whole bunch of these. I think, in an elderly patient, primary suture repairs, they're great, gets them out of trouble, keeps them safe. They probably don't need the Cadillac polyperistomal hernia repair. In general, if it's a younger patient, I would probably stay away from a primary suture repair. For your mesh repair options, you have your laparoscopic and your open repairs. I think, these will sort of merge as we get a little bit more comfortable with our robotic TAR experience and start adding the peristomal hernia repair to there, so they'll kind of overlap. But I think, when approaching this, I will say, for a small peristomal hernia, really no midline component, a lap Sugar Baker is probably the best thing for those patients. You can kind of choose to or to not close the hernia defect. I think, there's literature that supports both, but I think in terms of an MIS repair, this is a really good repair. I will say that there's probably a little bit of discussion about this when you have a large peristomal with a big midline component or also another stoma defect and you're considering a posterior component separation. The first question I would ask is, do you need to relocate the stoma? And when I meet with patients at clinic, I always ask, do you like your stoma? Are you happy with it where it is? Are you having problems pouching because you can't see it or stuff like that? And I think, if they are happy with it and, if it looks and is working okay, I would do everything you can to kind of keep the stoma where it is. And then perform a Sugar Baker on that. If you need to resite it, then I think a keyhole or a polyperistomal are equivalent. And if I had to choose between one or the other, if I could lateralize the bowel, I probably would do a polyperistomal versus a keyhole. Just because of the bias of mesh erosions and really it's really quite difficult to get things all aligned. And so, you did a great job in the OR. You're super happy with how things went. The patient was really happy. And then, you're following up your patient and 2 years later, they say, oh my gosh, I'm having problems pouching again. And you've done your polyperistomal and you get the repeat CT scan and you're just devastated because they have a recurrence. The first thing I will say is we have noticed that sometimes recurrences aren't recurrence and you have a little bit of redundant bowel in CT scan, so just be cognizant of that. The other thing that I think you need to do is really kind of have a sit-down talk with the patients, especially if you've done any sort of posterior component separation in a peristomal hernia repair, about what actual symptoms are they having. Is it pain? Are they obstructed? You know, is it an unsightly bulge that they're having a problem with? And I think really kind of trying to tease out how symptomatic it is. Because I think if they're like, well, it's a little bit of a bulge, but it doesn't really bother me and I'm totally fine, you know, probably not fixing them might be the best thing for those patients. And then secondly, if they're like, well, you know, it's causing me a little bit of problems, or we just fixed a lady the other day that had ulcerative colitis and she needed scopes and she just had a small knuckle of bowel in her stoma. I mean, a minimally invasive approach, whether it's a onlay, a local repair, you know, it is a decent option for these patients. And then lastly, you know, do they need a redo TAR? And I have had the wonderful pleasure of doing a couple of redo poly peristomal hernia repairs, and those things are a battle. A loop of bowel that you're trying to protect. I will say this is of no data at all, but you know, this is kind of when you're seeing a patient and they thought that they needed a few redo peristomals, and there has been stratus that was put there just because of either the previous surgeon or us operating in a trial. That repair or redo was actually quite nice. And so I think that, you know, when the data comes out, it'll be an interesting way to interpret it. If there was truly no difference between a biologic versus a synthetic and someone that has a peristomal hernia repair, you know, that might be someone based on anecdotal evidence alone that, you know, if you know that you're going to have to do a redo TAR sometime in the lifetime of this patient, then that might be an option. But I think, you know, when you see young patients with stoma defects, I would kind of start from, you know, if possible, least invasive to most, because you know you're going to see them back, and it's okay to deal with the recurrence. And I think you kind of just have to pick your battle of what recurrence you want to deal with. And so upfront offering them maybe not the best repair, but something that will be durable for some time and save yourself some normal anatomic planes down the road is kind of the best way to approach these patients. And so I will kind of finish with this. This is a patient that had a keyhole. That's actually a piece of sugar baker or stratus there. You know, already had a big previous repair, and now you have to kind of deal with this. And obviously when you have, you know, that's sort of the thing that kind of guides my decision making when I see these patients. And so trying to do the least invasive thing first, and then kind of advancing, and then just be kind of aware of the limitations, and hopefully eventually we'll get some good data about what is better. And it might not be that anyone is better, but I think the best repair is one that you're comfortable dealing with and comfortable doing. And so those are the ones that you should offer the patients. And if we have a little bit of time, maybe at the end, we can go over some cases here, because I've actually had the pleasure of doing a couple of these already.
Okay. So thank you, Charlotte. That was very interesting and very mature. And I think because of the time involved, we will keep the discussion towards the end. And we are joined by my dear friend Pramod Shinde as the panelist, along with Pradeep. So we will have their comments towards the end. So let me just call on Jignesh Gandhi to give his talk. Can you unshare your screen? Charlotte, I suppose you're done now?
I should be unshared, am I?
Yeah, yeah, that's good.
Yeah. Okay, good evening, everybody, and A very nice presentation, Charlotte. I really enjoyed, and we're going to have some overlap of the slides because I have shared some of the data from yours, and I have no conflicts of interest for my talk. But I've taken lots of material from Up to Date, which we have an official subscription at our hospital, and also from the Atlas of Abdominal Wall. And special thanks to Yuri and Eric, for taking a personal communication to help me get some of the pictures which I have used for the presentation today. Thank you very much. So open to MIS was a top given to me, and I have divided very basic because GMAS has a focus that it is for even a postgraduate student to a consultant level. So I just thought that I'll divide my talk into anatomical and radiological classification, principles of repair, go on to laparoscopic approach, open approach, old and new, and do we have any preventive measures today? So if you see, the radius of the stoma influences the hernia formation. So there's a little bit of physics behind it. And this paper said that if you have an ileostomy versus a colostomy, as the radius keeps on increasing, the bigger the diameter, the bigger is the tangential force from the core muscle. So it's a very basic understanding that stomas created from the colon have a larger propensity for formation of hernia compared to coming from the ileum. So given a choice in a situation where you're going to do a permanent or you're going to do a temporary, in temporary stoma, I think one should probably prefer an ileostomy to doing a colostomy so that you stand a lesser chance of a parastomal hernia. So if you see the incidence, Charlotte has already gone over it. The end ileostomy ranges up to 28%. So the end colostomy and the loop colostomy, if you see, it ranges anywhere between 40 to 50%. So overall, you have about 50% chance of stoma or a herniation if you have created one. Coming to the anatomic classification, the classification is required because we need to have documentation. So sometimes people ask that why do we need to classify a parastomal hernia? I feel it is to document standardization of the technique which the forums like this are meant for. It also helps for the hernia registry and it becomes a good teaching tool. So if you see, we have 4 different types anatomically, and the most critical one is the interstitial because this is where the bowel loop is between the muscles, and the highest risk of strangulation is in interstitial. So that is what happens. So this is again a diagrammatic representation of an interstitial. So clinically, one should see, just classify into what kind it is, and then you know that which ones you're going to take them as a priority because this have a high chance of complication. Radiological classification, it is based on this paper which had come out much earlier in 2007. And the first is type 1A, where the sac diameter is less than 5 centimeters. And then you have a type 1B, which is more than 5 centimeters. Then type 2, where the hernia sac contains omentum, as you can see in this picture. There is a stoma here, and this is the fact which is represented on the stoma, which means that there is an omentum. And the type 3 is a sac which has got a different bowel loop from the hernia itself. So sometimes if you're doing an ileostomy, you may have the same loop, but if the loop is different from what is there in the stoma, it will constitute for type 3. The principles of repair of a parastomal hernia, obviously primary hernia repair was in the past, but it almost had a very high chance of recurrence. Then came in the mesh repair, which was done by the open and the laparoscopic technique. And then obviously we have the option number 3 now, which is the relocation of the stoma. So we have these 3 principles on which we have to work around. Practically, Charlotte has given you an algorithm, and I'll also give an algorithm based on similar, which Eric has suggested, and some of my inputs at the end of my talk. And the mesh, whenever you put in the parastomal hernia, it again is in a different plane. So you have an onlay mesh, sometimes you put in a sublay mesh, or sometimes it's an IPA mesh. So depending on this, also the repair of the hernia keeps on changing. And according to that, you have different chances of recurrence. So if you see, the recurrence of the parastomal hernia is lowest when you put it in the sublay mesh. So again, like the principles of any other hernia repair, the more and more the hernia mesh remains in the sublay plane, it has got a better chance and lesser chances of SSI and SSO. So if you see this landmark paper which had come up in 2005, they had recommended at that time, almost 15 years back, that the parastomal hernia and putting in a prophylactic mesh in these kind of patients. This is what was put in that paper, a Vipro mesh, and this is what the slit was made. So they have also mentioned about relocation of the stoma and then putting in a large mesh, 2 pieces of mesh, one around the new stoma and one around the area where you have already created one. So how does one approach to a parastomal hernia? So if you're going to go for a laparoscopic approach, usually it is recommended up to 8 centimeters, but there are papers where they have done even up to 12 centimeters laparoscopic approach for a parastomal hernia. If you anticipate less adhesions based on the imaging, then probably this is a good case where you're going to take up for a parastomal hernia repair. And by and large, today with a good reading of the CT scan, we can make out what's happening in the abdomen. And good experience in laparoscopic IPOM or IPOM plus definitely helps you to do a good laparoscopic parastomal hernia repair. So these are the techniques in which the mesh is either sugar bakered in this way, or you approach and make a keyhole technique. This is again where you roll in the mesh in a different plane and then you refine it in one direction and then you roll it out. I use a Foley's catheter and it has been recommended for the dissection. But what I feel is that the Foley's in the sugar paver also prevents the narrowing. So once you start closing the defect from one side to the other side, what happens is after you've put in the mesh, when you're going to fix it around the stoma, putting in the Foley's catheter at that level, at the entry point and keeping it inserted by about 15 to 20 cc of saline, and then you're going to fix the mesh, it reduces the chances that you can have an obstruction there, because quite often in the literature is mentioned about that. So I do not only use the Foley's at the time of dissection to identify the correct bowel loop, but also Foley's at the time, at the area where the stoma is coming out, so they can prevent any narrowing in that area. So laparoscopic hernia repair, if you see this keyhole versus sugar baker has a chance of almost 11.6% recurrence. The keyhole has about 11%, and the sandwich technique is about 2%. Coming to the open approaches. So in open approach, you have option of relocation of the stoma. And when you're going to relocate the stoma, you don't not only put the mesh at the primary site, at the index site, but also at the site where you're going to relocate the stoma to prevent another hernia formation there. And this is a technique in which you're going to put in the mesh. When you're going to put in an open, again, it's a rolling technique. And the keyhole is again of two types. There's a keyhole, and then you have the mesh put in there, and then you roll it up, and then you go by the approach there, and then you put in the mesh. Coming to the sugar baker technique, again in sugar baking technique, what I told you about was the putting in the mesh in that area, putting in the Foley's catheter there, and then trying to do that. What are the newer open approaches today we have? So if you see this paper by Eric, which is very popular now, and a lot of us have been doing this, it works out very well. You lateralize and then you sugar baker the mesh in that area. So again, the same picture which was mentioned earlier. So you create a hole into the PRS once you have done the tar on the top and the bottom side, and then you go around that area behind the stoma to create a tar. You come back here and then you lateralize the bowel, and then you put in a piece of mesh. This is from his cadaveric model, and very nice description about how you can perform this. It requires a little bit of technical expertise, and once you have done a lot of tar, then one should venture into doing this, because doing this as a primary technique, it's very, very difficult to understand the anatomy in that area. So this is how it looks like, and this is how you lateralize the stoma. And this is the completed result of the repair. And then you put in the mesh, and then you put in a large piece of mesh in that area, and you sugar baker the mesh in that area. This is again a diagram representation of the same thing. And then you have another technique where you would probably do a new stoma, close the old stoma side. So again, a large piece of mesh where you will be having a mesh at the previous side as well as a mesh at the new side. This is one of the patients which was referred, and then we had planned for this surgery. Now, in case if I'm going to do up, this is the way we did it. We went around with the polish repair. This was a patient with a carcinoma rectum where an APR was done, and then went ahead and did a tar, went around it, then created the opening there, and then I put in a large piece of mesh, and this is the end result of that case. So this is how you can achieve good results if you know the technique pretty well in advance. So the thing which is important in such patient is, suppose if this patient was for some other indication and we have to relocate the stoma, you not only put the mesh at the site from where you have relocated, but you have to put in a large piece of mesh. So it is very, very important that both the sites are covered up adequately, because if you're going to put in a mesh here, and if you're not going to put in a mesh here, you may again stand a chance that this patient might come back with a recurrence. So whenever relocation of the stoma is indicated, one has to remember that you cover up with the mesh adequately. So there was a study which compared about 10 types of different open repair, right from primary, which is the highest % of recurrence, and then so on. If you see, as you keep on doing the sugar bear or the keyhole, the recurrence rate keeps on dropping down. And obviously, if you're putting in the mesh in the sublay area, the recurrence is around 7%. Then another new technique, which is known as a SMART technique. This is from the paper from the UK group by Norman Williams. It's a very nice technique where you do a staple reinforcement. So this is the way you put in the staple through the created site, and then you mesh and everything together. You put in a stoma with the circular stapler, and then you take the piece of the bowel out, and then you suture it in that area and fix it. Another newer approach, which is also known as approach with a linear stapler. So this is the approach when you're going to close the stoma. So what they did in those cases was that if you're going to take down this stoma, after you take it down, what you would do is either a primary repair or you would do a primary repair with mesh. What they did in that repair was they put in a stapler, a linear stapler to close that. Technically, to me, it sounds a little difficult, but this is what they did, and they found that the results were much better compared to a primary fascial closure in this kind of patients. And on top of that, they put in a mesh. So this is how it looked like preoperatively, and this is after the stoma closure with the use of a linear stapler. Another method, which is also known as a hyper technique, this is popularized by the group from Poland. What is done in this technique is there are different stages of operation. So the first stage is laparoscopic approach, where you do adhesiolysis by going in with a laparoscopic approach. Next is keeping the carbon dioxide inside the abdomen. You dissect the sac around the stoma. And then once you have done the complete dissection, so what they say is that when you keep the pneumoperitoneum intact, the sac dissection becomes very, very easy. Once you do that and you've dissected the sac, you open up the sac, then obviously deflate the abdomen. Now you close the defect. The next is that introduce a Dynamesh IPST. I will just show you a picture of that. Through that opening, insufflate it again, and then you fix the mesh. So it's a combination, like a hybrid approach where you start with laparoscopy, do an open approach, and then again come back to laparoscopy, and then desufflate the abdomen and then mature the stoma. So this is a typical mesh, which is known as Dynamesh, and this typically has got a hole through which the stoma can be brought out very comfortably, and that's how you can do this repair. A very popular technique by the Urinovsky group called the STORM technique is another good technique where you do a staple transabdominal ostomy reinforcement with the retromuscular mesh. So this paper mentions about the technical details, but this is how it is done. So that's a penetration in your posterior fascia. Then the bowel segment is over there. What you do is alignment. So the most important is the alignment, because if you have not done the alignment of all the layers properly, if you fire the stapler, then you can have different areas where the staple will be fired, and then you can have a technical problem. So alignment of all the layers, then putting in the anvil in this way from inside through the mesh, and then passing in the circular stapler from the top. And once you have done that, you fire that area. Now, once you have fired, you have a proper hole with the mesh in situ. Now you deliver out your bowel through that area, externalize the bowel, close the midline, and then you can prevent herniation. Coming to the bit of prevention, if you want to prevent a stoma, then these are the ideal sites for prevention of the stomas, ideally so that you go specifically in the obese patients. These again are the sites. So sometimes we have done stoma in obese patients in emergency, and then we find it very difficult. So in a large panel, it is always better that you prefer the upper abdomen, because the distance between that and the anteabdominal wall is much, much slower. So avoid the folds and try to relocate and find out the possible point from where you can bring it out so that you can prevent a complication there. From my personal experience, let me share something which we do. So if you imagine this is the area of the abdominal wall from where you're going to bring out the stoma. If this is seen from the top, okay, this is the hole which you have created in the muscles. Normally, the tendency is that you take out the bowel and then take the sutures. This I have learned it from Dr. D'Souza. So what we do is we take full thickness sutures with the hole, and we can see all the layers together. Once we have done that, I'll show you what exactly happens. So I have taken the full thickness sutures in the anterior abdominal wall. Then I bring out the loop, and then I put in my loops there and take out the. So what happens is that when I've taken the stitches, it goes through all the layers. Now, suppose if you do it the other way around, you bring out the bowel first and then you take the sutures. This is what exactly happens, because if you are retracting in an obese patient, quite often I've seen my residents, they will just take the superficial layer or just the anterior fascia. And once you just take the anterior fascia, what happens is that you're going to leave behind, and these are going to be superficial bites. God forbid this patient has got a raised intraabdominal pressure post-operatively, it can be troublesome. So this is a small area, almost about 3-4 millimeters, which you leave behind if you do it by this technique. So this technique taught to me by Dr. D'Souza works very well. I even do it for my temporary stoma, and we've hardly seen any patients coming back with having a parastomal hernia. So practical algorithm, which I discussed and I saw from Eric, a small parastomal hernia, the midline hernia, which are less than 5 centimeters, you'll do a laparoscopic sugar baker. Moderate to large parastomal hernia with a midline hernia, you would either do a posterior component separation TAR. Along with that, you want to do a stoma relocation, that is fine. Or you can do a cruciate incision versus a storm technique. And if the stoma cannot be relocated, then you'll do a PCS TAR with a keyhole mesh approach. So this is what you will be using in your practical terms. Let me share you with a CT how I decide. So this is a patient who has a hernia and has come back. So this is the patient who had come to in our emergency with a pain in abdomen. If I'm going to do a resection and anastomosis in this patient, and I'm going to do a stoma, look at the muscle. So what I look at that is the rectus muscle and the core muscles. If I feel, look at this patient, they're pretty good and pretty bulky. So in this patient, if you're going to do a stoma, probably you may get away without doing it in a mesh because you've got good core muscles there. And with the D'Souza technique, which I showed you, if you take good sutures, you'll probably stand a lesser chance. But look at this patient who had just come to an emergency with a growth in the splenic flexure and in an obstruction. As you keep coming down in that area, look at the rectus muscles and look at the core muscles. Look at this. These are absolutely thin and frail. Now, in this patient, it's an ideal indication that you're going to probably use in a stoma with a mesh prophylactically, because if I'm not going to use that mesh, these frail muscles are probably going to stand a very high risk. So whenever we create a stoma, we look at the CT scan, and this is the way we approach our patients, that we look at the bulk of the muscles, and that probably helps us. We are collecting our patients now, and we will probably soon come out with the data. So stoma with a prophylactic mesh, according to me, there are two cases, an ileal conduit or a C rectum with an end stoma. These are the cases where you'll put in a prophylactic mesh. The reason being is these are usually cases of malignancy. They have low in the proteins. They have very thin core muscles. Second is if they have an increased intra-abdominal pressure or cough, these patients will stand a higher chance. And the golden question in this patient is going to be the mesh size, the plane of the mesh, the trifine, and the shape of the mesh. So there are a lot of variables, but I think in patients with malignancy, one should exercise that we should try to put in a prophylactic mesh. Obviously, the surgeon's experience and the evidence-based medicine makes the algorithm very simpler, but these are roughly the ways in which you can do your open or laparoscopic approach. I thank you very much. And this is the last slide, which was in the IHC from Mike Rosen, where the patient had an erosion into the mesentery, and that's where the patient had landed up. And a similar picture was also shared by Charlotte. So this is what can happen. So the jury is mesh or no mesh. I think it's surgeon's experience, the demographics of the patient, and the evidence-based guidelines together, which will make the final outcome. So thank you very much. This is my AWR team from India, and I thank Dr. Ramanna, Dr. Dev Kumar to give me this opportunity. And I'm always approachable for any kind of discussion or sharing of information. Thank you very much.
All right. Thank you, Jignesh, for yet another comprehensive talk. So we will get on to discussing with our panelists. And
Ramanna, we can't hear you. I think you're on mute.
No, I'm not on mute. Can you hear me? Others?
I can hear you. I can hear.
Yeah. Right. So let me ask Pradeep. Pradeep, as a colorectal surgeon, you're based out of Kent, UK. Do you handle parastomal hernias yourself, or do you refer them to an AWR unit? How do you handle parastomals, and what is your perspective on handling this particular condition?
Thank you. Thanks for the speakers, by the way. It was an excellent talk. In UK, we consider parastomal hernia is still part of colorectal surgery because we are the ones forming it. So we believe that we should probably fix it. I don't know whether that's right or wrong, but we're the ones who are trying to fix what we have created. And I suppose the ones we try to send for specialized centers are the ones which is associated with a complex incisional hernias. So as long as they have got a simple parastomal hernias, we deal with it, and we tend to sort of follow the European Hernia Society classification of grade 1, 2, 3, 4, and 5. So those are the ones we tend to deal with it. I don't think any colorectal surgeons normally refers to other centers unless, like I just mentioned, there are complex incisional hernias. I hope that our NICE guidelines, which is the National Institute of Clinical Excellence, has advocated repairing these hernias. And we've also now got guidance that we could use either biological or synthetic mesh, because these are sort of a clean contaminated cases. Although we were very apprehensive a few years ago of using synthetic meshes in these infected cases. So I think in Europe we are sort of bounded by the NICE guidance, the Association of Coloproctology guidance, as well as the European Hernia Society guidance.
Okay. So what kind of repairs do you generally do for these hernias? Do you primarily tend to get smaller hernias which you sugar baker?
Yeah, it's a very good question. And I think it came down with the speakers that no matter what you do, the results aren't brilliant. And I think you have to really tailor these for the cases, whether they present with an emergency. And although suture repair does have a high recurrence rate, they may be ideal for emergency cases, for example, or people who have with significant comorbidities. But as a principle, what we have decided to do is we've learned that no matter what we do, hernias do occur and the repairs are bad. So we try to prevent it and see whether we really need to give a stoma. So we gone back thinking, does everybody need a stoma? Do we have to do an AP resection, or can we get away by doing an ultra-low anterior resection, for example? And if I can't do an ultra-low anterior resection, can there be somebody else who could do it? Can we use a robot to do it? So that way we are trying to prevent the stoma forming in the first place. And those who do need a stoma, do we need to put a prophylactic mesh in the first place? So we sort of gone down of preventing it. When it does occur, I think we more or less have some similar sort of an algorithm what Charlotte sort of presented of not going blind and saying everybody needs a sugar baker or everybody needs a laparoscopic surgery. So we sort of have an algorithm where we tend to lateralize the stoma and definitely try to put a mesh, because I think repairing a parastomal hernia without a mesh probably has got quite a high recurrence rate.
Right. So, Charlotte, if you have a case where you have an ileal conduit and a parastomal hernia on that, the patient's undergone a radical cystectomy. We all know that there is a paucity of peritoneum in the pelvis and the lower abdomen. So, have you had encounters where you find major loss of peritoneum or any kind of cover in the lower part? And have you been tempted to use coated meshes in such situations?
I fixed one of these on Monday, actually. And you know what? So the answer to that is no. I think what we have done in those situations is the operation that I offered the patient on Monday was because I knew that they were going to be missing some of those abdominal components, was a laparoscopic sugar baker because their defect was very small. I think that if you're dealing with a complex one, we have been able to get back lateral enough in order to get coverage, to get things together. And so I've not encountered a situation where we've had an ileal conduit where we haven't been able to, we have taken our dissection way laterally to kind of make up for the defect that's there. I think ileal conduits are very, very tricky hernias to repair for a lot of reasons. Number one, the length of the conduit really matters, especially if you're going to try and sugar baker it. A lot of times the ureters may insert in a way that doesn't allow you to sugar baker it, and you may kink it. And then on top of that, if you need to recite it, that is also a really big problem, just because you have to deal with the ureter insertion. And I think when we are repairing these, or when you're approaching them, it makes sense to work with urologists in order to kind of really understand the anatomy and what they can do. I mean, obviously, if you have like a huge loss of domain and have a lot of problems, there can be things that can be done from a staged approach, whether or not they need to add to their conduit or something like that. But again, all of these patients are extremely complex, and it's kind of a case-by-case basis as to how you're going to approach these.
Okay. So Eric Polai is here, I see. Eric, let me know if you're willing to come up and say a couple of things.
I'm just lurking, Ramana.
Okay, all right. Okay.
No, I'm happy to say a few words, though. I think, honestly, I think that Charlotte and Jignesh did a really nice job. I mean, these are, as I think appropriately been pointed out, all peristomal repairs are challenging. There's no ideal solution. And so being aware of these options, thinking critically about the patient and you know, going into the OR with a plan A, a plan B, and a plan C is obviously very helpful.
Okay, fine. Pradeep, you were saying something. You'll have to unmute yourself.
Yeah, sorry. I was just going to say, which I wrote it down, but I missed it, is one of the things we probably didn't talk about is our stoma nurses plays a key role in this parastomal hernia sort of a management, right from the point of addressing to the patients before they have one, educating them about it, where the stoma is going to be sited. And when they do develop, actually simple things which will sort of putting the bag on and, you know, their lifestyle, you know, stopping them smoking, reducing weight. So our stoma nurses plays quite a key role. And we tend to operate only on those who have at least spent at least 3 to 6 months with in the stoma clinic before we even start repairing them.
Okay, nice. Pramod, do you have any take on the talks? I think you probably heard most of Charlotte's talk.
Yeah. Yes.
Yeah. And if you have any questions, that's also something you can throw up.
Yeah, I liked quite a few points from Charlotte's talk, and so did I like some points from Jignesh's talk. What I liked about was that the keyhole technique, where you need to keep the layers absolutely aligned. And that's a very, very significant point, and both of them have really actually highlighted that point. I wanted to ask Charlotte that wouldn't a storm or a smart technique help you to keep all those layers aligned using the staple technique? That was one of my questions that I wanted to ask.
I certainly think that it can. That's not something that we normally just made the defect. I would love to see it in action. But I think that, you know, there are things that can, even in those situations, cause problems, like making sure that your mesentery is straight. And sometimes, you know, even when you have things aligned, you can still have problems. And so I think, you know, just being aware of all of the layers that you have together and having a really low index of suspicion when something isn't going right is key. Because not only, and I think this is kind of what we noticed when we were fixating the mesh, is even though stuff is aligned, you still have all these forces interacting in a way once you have that mesh next to that stoma. And those things can be a little bit unpredictable. And so I think that, you know, if you get things perfectly aligned, whether it's just with the stapling technique or the storm technique, as you mentioned, or just, you know, you're still going to have problems. And these are just complex cases.
Okay.
Yeah, Jignesh, you were saying something.
Yeah. It's just one practical thing which I have seen in emergency surgeries, because how big the hole is enough to bring out the loop is always a golden question for every surgeon. We have done cruciate, we've done a transverse incision. I have myself been in a witness where the patient was extubated, and with that forceful cough which the patient had, the bowel just popped out in the recovery room. And I've gone in, and on the bedside I have done and pushed it, and I'm sure each one of us has gone through that. So in emergency situation, whenever you have an edematous bowel, I think that's where this technique helped us, that we took sutures all around, and that's where I could plug up that opening like a clock, you know, going around all, rather than just taking the post transfacial. So I'll be very happy. I'm seeing smile on everyone's face. Everyone wants to discuss about it. Yes, Dr. Pradeep, you can start.
tell you what, with the COVID around, none of our patients are coughing in theater anymore. The anesthetists are very careful in waking them up. But no, I get your point. I was going to ask you, Jignesh, the fantastic job. You know, when you showed your diagram of suturing with the bowel, were you suturing the sheath with the bowel wall 2 or 3 centimeters proximal to the stoma edge? I couldn't grasp it.
Yeah. So what we do is, once I've made the hole, okay, we take sutures all around with the full thickness of the muscle and just keep them like we do it for any hepatobiliary surgery and keep them mounted on the clips. Then we take the bowel out, and once we have taken the bowel out, then you take the seromuscular bite, depending on whether you're going to do a Brooks ileostomy or you're going to do an ileostomy, because quite often what is done is the reverse. The surgeon first takes out the bowel, puts in the right angle retractor, and then he tries to take the sutures. This is where in obese patients, you tend to take just the superficial sheath and you then take the full thickness. By taking that full thickness before and then delivering the bowel out, I think you're going to get a very good grip on the bowel. So this is what has helped us a lot. And this is a routine practice which is done at Tata Memorial Hospital. Dr. D'Souza has popularized it, and I was happy to learn from him, having spent some time there, and it works very well.
All right. So I have another question for either of you, Charlotte or Jignesh. Can you advocate placing stomas outside the rectus compartment, laterally?
So if you ask me, the tangential forces will be more from the core muscles and the rectus abdominis. And if you look at the paper which I talked about, the radius, if you place them more laterally onto the core muscles, you will have a higher chance that the defect is going to grow bigger over a period of time. This is what the physics tells me. And that's the reason I think we should have a part of rectus always included. I think a lateral stoma would be a bit of challenge, but yes, a lateral stoma in the core muscles with a mesh probably would be a good option, because you're putting in one more layer of reinforcement, and probably that might change the physiology or the physics of dynamics in that area.
Charlotte?
I would say I'm not a huge fan of that, mostly because now you're fixing, I think it's really hard to make sure that you're lateral enough and that you have enough length with your bowel. And then on top of that, like making sure that you're not sighting it through the linea semilunaris can be a problem. And so I think, the nice thing about sighting this through the rectus is you have pretty good anatomical clues that you're in the right spot. And I think sometimes those can be lost if you sight it out laterally, and they can create more complex hernias to fix down the road.
All right. Pramod, you were saying something.
I had a question for Pradeep, and in fact, 2 questions. One of them was this prophylactic mesh. Do you put, and do all surgeons in UK put prophylactic mesh for all your parastomal hernias? That was my first question. The second question is, if you have a recurrence of your own parastomal hernia, you've repaired it once, and you again have a recurrence, would you do it yourself or would you send it to a hernia surgeon? Because that specialty is coming up in a big way. And I think parastomal hernias, because of their massive recurrence rate, wouldn't that warrant it?
Yeah. I don't think everybody is talking about the prophylaxis. I don't think everybody is putting prophylaxis, because the guidance says that it's recommended, provided your clinical governance is set in place and you're auditing your how many meshes you put in. So, and also it's quite technically challenging to most colorectal surgeons to put this mesh as well in a recto-rectus space, especially when you're doing laparoscopically, you don't have much space there. So although you may be able to put it as an IPOM, not every colorectal surgeon is trained to put a mesh. So the answer is no, not everybody is doing it. So only few centers are doing it, or certain people within that center are doing it. When you ask me that if I repair it, will I keep on sending it? I'm in a slightly unique position, because I get all the complex hernias to come to me. So I'm already seeing somebody else's hernia. We have, over the period of time, transferred patients to other centers. That is probably because of a little bit of a political reasons in terms of because the patient had waited too long and was not very happy and satisfied with our institution. So that was the reason to send it. But so far, we have been able to manage most of our hernias in our own center. What I see now is because of the COVID is that all these routine operations have been delayed. So I now see that it's a simple parastomal hernia, which I put on the list to be operated now. I'm sure by the time their turn comes to be operated, it's going to be much more complex. So we may be revisiting them and bringing them back to clinic to reassess them again. And the problem I have is, when I was in Institute, it's the same problem in London, Birmingham, and other centers. So even for me to transfer to them, they are going to be inundated as well. So I think the world is going to slightly change, and especially for parastomal hernias, simple ones will probably become worse.
All right. So I think we're reaching the very tail end of the session. I would like to ask Dev Kumar Roy to take over and pass comments and close the session.
Yeah, thank you very much, everybody, for joining us. Special thanks to Charlotte. Even Eric Pauli came. I didn't believe it. He's going to come. And thanks, Dr. Shinde, for joining with us with a short notice, and Pradeep also. And thanks to my dear friend Ramanana. And that was a fantastic meeting, and it is a very specialized topic. So I don't think we'll have a huge crowd joining and listening to us. But those who are interested, they have joined. We had about 40 plus, I think, at least keen candidates who joined the show. So again, thank you, everybody. So we're going to finish the session tonight. Thank you.
All right. Bye-bye. Thank you.
Thanks for inviting me. I enjoyed the session, and I'm glad you invited me. Thanks.
Thank you very much. Thank you.
Thanks, Pradeep. Bye.
Thank you.
Thank you so
Thank
much.
you, everybody. Thank you. Bye-bye.